I would like to call Dr. Prashanth on stage. He'll be speaking on suboptimal ovarian response, the role of endocrine, genetic and iatrogenic factors.
He is a professor and head of the Department of Reproductive Medicine and Surgery, Kasturba Medical College, Manipal. He has many publications, national and international journals, and he will be speaking to us on the suboptimal evaluation of ovarian response, the role of endocrine, genetic and iatrogenic factor. Over to you, sir.
Good morning. At the onset, I would like to thank the organizers for giving me this opportunity. Greetings from the temple town of Udupi and the university town of Manipal. These are the learning objectives for the talk. So, now we all know what is the end point of IVF outcome. Initially, they used to concentrate on clinical pregnancy, then it went on to live birth rates, then cumulative live birth rates, and then now the present thinking is completing a family from a single oocyte retrieval cycle without having a complication of OHSS or multiple pregnancies. Now the outcome, the IVF response may be poor responders where you have less than 4 oocytes. Then you have the suboptimal responders where it is between 4 and 9 oocytes, and the normal responders 10 to 15 oocytes, and the hyper responders. Now there is not much of difference between normal and hyper responders, because ideally everybody should be a normal responder, because the number of oocytes which we get is about 10 to 15, and you have the optimal pregnancy rates, whereas in the hyper responders there is a high risk of having OHSS with no increase in the pregnancy rates. We are in the era where we need to have a OHSS free clinic. Now what do you mean by a suboptimal response, and in what way is it different from a poor ovarian response? I would like to say something. Somebody who is doing academically very well, in the final exam, if they do not get good marks, then you call them a suboptimal response. Whereas somebody who is not doing very well in academics, you are expected that he will not do very well in their final exam. It's a simple analogy which I can give. So what is the diagnostic criteria? When there are no follicles greater than 10 millimeters on the 6 to 8 days of ovarian stimulation, we expect the follicles to grow beyond 10 millimeters or at least 12 millimeters on day 5, day 6. And that is reflected by the serum estradiol level less than around 200 picograms per ml on the 6th day of ovarian stimulation, and slow growth. We usually expect the growth of the follicle around 1.5 millimeters per day when you are using a supraphysiological dose of gonadotropins. Now, suboptimal ovarian response is different from poor ovarian response for the simple reason that patients with suboptimal ovarian response have normal age, less than 35 years. I think Rubina discussed about the ovarian reserve markers and the normal sex hormones, and they have a normal AMH and normal AFCs. And whereas a poor ovarian response, they have decreased number of follicular number, that is on day 2 you find that the number of follicles are less, and on the day of HCG administration you have a low estradiol levels, and these patients consume more of gonadotropins, and the end result is they have decreased oocyte retrieval and of course poor clinical pregnancy rates. And remember, these patients have advanced or normal age, okay, and what is more important is they have poor ovarian reserve. I told you, somebody who is not doing academically well, you can always expect them not to perform very well, right? Now, if you look at the Poseidon criteria, now 1B and 2B, we all know that 1B is suboptimal group where we get about 4 to 9, and 1 is when the age of the patient is less than 35 years, and group 2 is when the patient is more than 35 years and we are able to retrieve anywhere between 4 and 9 oocytes. Now the incidence is about 11 to 15.5%, and what is more important is we are looking at a normal ovarian reserve, and we tell the patient, yes, we are going to get good number of eggs, but at the end of the day we get only few oocytes, and then you have no answer for the patient. The patient is going to ask you, doctor, you said we are going to get good number of oocytes, but why is this? So causes of suboptimal ovarian response. sorry. One is, if you are using a long agonist protocol, I think the need for long agonist protocol is much less. There is a profound suppression of this hypothalamo-pituitary ovarian axis, because of which the LH is very low. These are the patients where you can anticipate suboptimal ovarian response. In case of a antagonist protocol, then you have what is known as FSH or the LH polymorphisms, and then of course what is important is the suboptimal initial dose. Now, the risk factors being age more than 35 years, these patients are likely to respond less, of course, and we all know that after 35 years the ovarian reserve is going to drop. Then BMI greater than 25 kgs per meter square and a high basal FSH. In fact, I think more than 10 milliunits on day 2 of the cycle, you can always counsel the patient, yes, there is a possibility that you might have less number of eggs, your ovaries might not respond very well. Then AMH less than 2.97. Now, this is something which is very interesting, and AFC is less than 12. Now, remember, this is a study which is done in the West, where the patient, they age much slower than Indian counterpart. Probably we need to do a study and we need to have ROC cutoffs for our Indian population so that we can counsel them. And the presence of any female infertility factor, especially endometriosis, which is on the rise, where the number of eggs are going to be on the lower side. And then if you are going to use HMG, then this is one, because of the batch variation, you might have suboptimal ovarian response and a GnRH agonist trigger. Now, if you look at this particular ROC, it says that anything less than 2.97 nanograms can be a risk factor. It's not that everybody, but you need to be on the guard, and AFC also less than 12. Now, it is important how we identify these patients. Now, if you look at the graph here, on day 8, there is a marked reduction in the estradiol. That we all know that a follicle should produce about 200 to 300 picograms per ml. That is a mature follicle. But if you find that the estradiol levels on day 5, day 6 is less than 400, please be guarded. Now, agonist protocol, of course, if you find that the LH is very less than 0.6, that means there is a over suppression. That is a indicator to say that these patients can have a suboptimal ovarian response. And then the minimum follicular number. What do you mean by a minimal follicular number? Those follicles less than 10 millimeters, they are more. That means the initial recruitment has not taken place. And the number of small follicles, the small follicles are those between 10 and 15. They are less than 3 point, that is the average. Okay, you can have 3 or 4. And on day 12 to day 14 of the stimulation, you find that the number of follicles, minimum, number of medium follicles, that is 15 to 18 are only 2.5, and the progesterone levels. So, it helps us to counsel that when you have such scenario, you can always tell the patient. Now, this is the graph where you find that the estradiol levels are much lower on day 8 and day 11 as well. Then in case of antagonist protocol, if the LH is less than 2.4, I am sure many people must be doing biochemistry, we do biochemistry, and this helps us to counsel. And the LH-FSH ratio less than 0.57 will tell us, yes, there is a possibility that you can have a suboptimal ovarian response. And on day 9 of the stimulation, if your estradiol levels are less than 900 picograms per liter, yes, and the minimum number of follicles greater than 8, that means again the recruitment have not taken place. That means the number of follicles less than 10 millimeters are on the higher side. And day 12 to day 14, you find that a large number of follicles, that is more than 18, is less than 2.5. Now, how do we manage this? Now, I told you this is the etiology. Now, let us see what can be done. Now, in case of a long agonist protocol, as I told you, if the LH by FSH ratio is less than 0.61, then we know that these patients can have suboptimal ovarian response. So, what can we do? If the patient has had a previous history, then you can always give half dose of the agonist Okay, that can be done. And if the serum LH is less than 1, you can supplement HMG. If you are using what is a recombinant FSH, along with that you can add HMG or a LH, because that is going to compensate for the LH. We all know that the 2-cell 2-gonadotropin theory, that is required. LH is required for the androgens, which is going to be converted to estrogen to form a estrogen rich environment. Then different sensitivity to gonadotropins. Now, should we test for polymorphisms? There are some clinics where they routinely test, and does testing for polymorphism change our management? Now, this is the guideline. Should we promote the widespread use of the genetic information in clinical practice, since only a limited set of genetic variations have significant impact? It is debatable. But somebody who has had a suboptimal ovarian response, you can always get it done. Identification of genetic determinants for reduced ovarian response might lead to tailored medical approaches, reduce the overall cost of IVF treatments, and improve the COS efficacy. Another 2 slides. Then this is the study where they have said that if you find polymorphism where you have the SS genotype, you can use the highly purified FSH. If you have the NS phenotype, you can use the recombinant FSH. Then LH polymorphisms, you can add LH from day 2 of the cycle, that will have a better outcome. Then increasing the dose, if there is no FSH or LH polymorphisms, you can increase by 50 to 75 units, and if there is polymorphisms, you can use 75 to 150. You can always add LH if the previous cycle the need for gonadotropin was more than 3000 units, or a history of follicular stagnation. So, then the take home message is the incidence of suboptimal ovarian response is about 15% in ART cycles. The risk factors include age more than 35, BMI more than 25 kg per meter square, and the AMH being less than 2.97, and the AFCs being less than 12, and a high basal FSH, and controlled ovarian stimulation with HMG. And profound suppression of pituitary in the long agonist protocol is the cause, wherein you can always add a HMG, or you can reduce the dose of the long agonist in the previous cycle. Then FSH polymorphism may be tested depending upon the clinical scenario. Increasing the initial dose of gonadotropins may help in better yield of oocytes. Thank you.